Okay, hello everyone, welcome. We're going to get started. Just as an announcement though, if you're looking for The Future is Now, Improving the Lives of People with HIV, the room has been switched to 516. So if you're here for that session, you should go to room 516. Right? So my name is Cassia Wells. I'm a Senior Technical Advisor for ICAP at Columbia University. I'm helping to facilitate this session. We will start with some framing remarks that I recorded, followed by 2 more recordings hearing from community members. And then we'll have a live Q&A session. So those of you online, please feel free to submit your questions online. This hybrid session is being co-hosted by ICAP's Sequin Project, FHI 360's EpiC project, the South to South HIV Prevention Learning Network, and the International Network of People Who Use Drugs. The format includes pre-recorded presentations in the community panel, followed by live Q&A sessions. I will begin by providing a framing presentation on the topic. Then we will have a keynote presentation from a representative of the African Network of People Who Use Drugs, followed by a community panel and a live Q&A. Then we'll have 3 case study presentations, followed by another live Q&A. Globally, it is estimated that there are 11.2 million people who inject drugs, of whom 1.4 million are living with HIV. UNAIDS estimates that 9% of all new HIV infections occur in people who inject drugs, and that they are 35 times greater risk of acquiring HIV than people who do not inject. This is in part because of the increased risk with parenteral exposure, as well as overlap with other key population groups and elevated sexual risk. There are also an increased risk of viral hepatitis and other bloodborne pathogens, with one study finding that almost 40% of people with recent injection drug use have viremic hepatitis C infection. When we talk about DSD from a health systems perspective, we are talking about a person-centered approach to HIV service delivery that moves away from a one-size-fits-all model and tailors services to diverse groups of people while maintaining the principles of a public health approach. This involves thinking separately about what services are delivered, by whom, when, and where. The what of DSD for people who inject drugs represents a package of services that should be made available. Of course, all services available for people living with HIV or at risk of HIV should be available for people who inject drugs. This includes combination prevention, testing, and treatment services, as well as management of other comorbid conditions such as TB, hepatitis C and B, and mental health conditions, including hazardous or harmful substance use. In addition, harm reduction services should be made available, which are evidence-based interventions that are based on public health and human rights principles and aim to prevent individual health harms without necessarily stopping drug use. There are 2 key harm reduction interventions, needle and syringe programs and opioid substitution therapy, both of which have been associated with significant decreases in HIV transmission. Best practices for needle and syringe programs include having no exchange requirement or limits on the numbers distributed, as well as the use of low dead space syringes, which retain less blood, as shown in the picture. It's also important they are integrated with other services, including wound care. Methadone and buprenorphine are the 2 drugs typically used for opioid substitution therapy. As you can see from the graph on the right, methadone has been used for a longer period of time globally, but in recent years more and more buprenorphine has been distributed. Other harm reduction approaches that are most often seen in high-income settings include the community distribution of naloxone for overdose prevention with user-friendly formulations, as well as the establishment of safe injecting spaces, which have a number of safety benefits, including preventing overdose deaths and reducing needle sharing. There are a number of different models for service delivery, each with some pros and cons. Major locations where services can be delivered are drop-in centers, through mobile outreach, and at fixed clinics. Other best practices include peer-led outreach with case management, as well as service integration and community-led services. There are also a number of ways to deliver harm reduction services. Needles and syringes can be distributed through the fixed sites, such as drop-in centers or pharmacies and vending machines, or through mobile outreach services. OST can be delivered through primary health settings or in specialized outpatient clinics, and while prescriptions are usually written by a physician, the medication itself may be dispensed by other cadre or in community-based clinics. Other speakers will go into this topic in much more detail, but it is important just to note that it's essential to address structural barriers in order to provide effective service delivery. It is also worth noting that a recent UNAIDS political declaration set targets for community-led organizations to provide services by 2025. Shifting now to focus on Africa, the UNODC estimated there were just under 100,000 people who inject drugs in Africa, with an 11% HIV prevalence and 19% Hep C prevalence. The diagram on the right puts these metrics in context of other regions in the world, and as you can see, Africa is below the global average, which is represented by the dotted vertical lines. However, there are reasons to believe these numbers will increase, as heroin trafficking routes have been identified in Eastern and Southern Africa, and based on population demographics, the UNODC estimates a 40% growth in the number of people who use drugs in Africa by 2030. When thinking about injection drug use in Africa, it is important to acknowledge that there are some significant data gaps, especially relative to other parts of the world. In this map, the dark gray countries are those with evidence of injection drug use, but no usable prevalence estimates at the time of the study. Similar data gaps exist when it comes to estimating the HIV prevalence among people who inject drugs on the continent. There is also a lack of data around the prevalence of hepatitis C as depicted on the left and hepatitis B as depicted on the right among people who inject drugs. There are also significant gaps in HIV metrics that are essential for program planning. On the left is HIV status awareness among people who inject drugs, and on the right is ART coverage. And as you can see, the majority of countries do not have usable data for these key cascade indicators. What data is available does suggest that people who inject drugs in sub-Saharan Africa are disproportionately affected by HIV, with incidence and prevalence rates that are 3 to 4 times that of the adult population. The UNAIDS table on the right depicts population size data by country and key population group. And as you can see, as of 2020, there were no countries in Eastern and Southern Africa that had usable population size data for people who inject drugs. In West and Central Africa, the overall HIV prevalence is lower, but people who inject drugs are still disproportionately affected. There are also more countries in this region that have usable population size estimates for people who inject drugs. In looking at the availability of harm reduction services, Harm Reduction International found that of the sub-Saharan African countries evaluated, less than half had any explicit mention of harm reduction in national policy documents. Less than a third had one or more needle and syringe program or opioid agonist therapy program. None reported any drug rooms or pure distribution of naloxone. Lastly, the vast majority of African countries have laws and policies that impact service delivery. According to UNAIDS data as of 2021, no countries had laws that permitted drug possession for personal use, and only 2 countries had anti-discrimination laws or provisions for people who use drugs, as reported by national authorities. In summary, providing accessible and acceptable HIV-related services for people who inject drugs is critical for epidemic control. DSD should include integrated harm reduction services, but also must acknowledge that addressing structural barriers and centering communities will be essential for successful service delivery. There is a notable lack of usable epidemiological and program data in the majority of African countries, but what is available shows that people who inject drugs are disproportionately affected by HIV, even in high prevalence settings. There remains significant unmet need for services, especially harm reduction services, which are hampered by political and policy barriers.
Hi, good day everyone from different region of this country, and my name is Ahmed Said, a staunch member of Kenya Network of People Who Use Drugs, and also I serve at the Regional Network of African Network of People Who Use Drugs as a board secretary, and I'm here actually to give the history and also the background experience when it comes to differentiated service delivery among the people who use drugs. Before I even go to the slide, is that one thing, why do we think the differentiated service delivery is important to the people who use drugs, is that there are many other aspects that people should be involved. When people think of people who use drugs, people should not only think of needles, syringe, ARV, condoms, and hepatitis drugs, but also people should be thought in other avenues. So for this, I'll go straight and start like the first slide that we are concentrating on this is that the DSD for people who use drugs in Africa is just a response to a person-centered approach that simplifies and adapts the bloodborne viral infections. And this one simply is that in many ways, we've been, personally, I've been in treatment centers where you are not supposed to ask the question. You are not be led to be the expert of your life, but you listen the expertise of a clinical person. So sometimes I think the DSD comes front to make us actually practice the three principles of respect, dignity, and human rights, because now the treatment should be autonomy, and also we need to have that consensual treatment approach. I should not be forced to any treatment. I should not be coerced to any treatment, but I should also be consulted and being involved. I personally nowadays get a lot of problem to ask questions. Even if I go there to treat malaria, we'll find the doctors sometimes they are not very comfortable. Secondly is that the beneficence, to maximize the benefit and minimizing the risk. Whatever kind of treatment or whatever program that is meant for the people who use drugs should maximize the benefit, should be less of risk. And also in this, we've been also experiencing the issue of biometric actually here in Africa, whereby people were told to engage in biometrics. But for us, it was actually maximizing the risk, because we are criminalized population. We are still a criminalized population based on many drug psychotropic acts we have in Africa. Lastly is the justice. In this, we need seriously to address the political and socio-economic barriers, the law that hinder us from accessing health, and also things that the social economic barrier are things that really bring back the dignity of the people who use drugs in terms of economic empowerment. However, something to note is that the DSD is still a subject of discussion due to limited resources in African health facility that serve the people who use drugs and also the key population. However, we really are happy with South learning, because there are ongoing learning that are taking place in different countries. There is gaps today and challenges that we need to face. Is that right now the OST take-home doses is a really challenge. I would say this, like last month we were sending somebody to a meeting where there is no methadone clinic or an OST clinic around there, but this person was told no, he cannot be given that dose to carry until he's accompanied by the service provider. So you can see how expensive it is to accompany somebody, to pay for a service provider to go and accompany someone. So it means the OST given, still the people who take OST have not been trusted yet, and that also demotivates the person who is looking for that treatment. There is also low enrollment. right now many clinics in Kenya and in other parts, they don't take new people. Lack of involvement in decision making that impacts the treatment progress of the people who use drugs, because now you will find a decision might be made, like the decision of carrying methadone with a service provider. That is a decision that was made in the absence of the community member in that table. Limited supply of naloxone. Actually, this is a very big issue here, because you are given naloxone that has a very short shelf life, 3 months to expiry date, 1 month to expiry date, and really that really doesn't help anyone. And then we also have most of our dropping center are run by the people who are not a community of the people who use drugs, and this is now very hard, because uh, they do sometimes monsterize their numbers, and they don't come in with respect to the people who, and also it also brings a barrier towards the rich. If you see a person who use drugs in a facility, they are either they are peer educators, but you can't see them in management and planning table of the program. Legal barriers also that exist. This also has been an issue, because right now as we talk, even in Kenya right now, I'll give an example of Kenya, like the Psychotropic Act also criminalized methadone. And here in Kenya, we don't even call it methadone. We call it a medical OST, but we call it medically assisted therapy, because the law does not allow the word opioid to appear in any. There are also no laws that protect the people who do service delivery, like those who distributing needles and syringe, because in Section 4 of the Psychotropic Act, you'll find that a needle and syringe is still a drug paraphernalia that is criminalized. Most community members also lack social protection, security, because most of them don't have medical covers. It's just the other day that we made noise, and now the peer educators serving under mainstream organization have been subjected to NHIF. But initially it was not like that, because of the low income status that we treating hepatitis C is also very expensive. People know that the hepatitis C and B is very saturated among the people who inject drugs. Recommendation and affirmation action is that we should try and scaling up the harm reduction services, making also health easily accessible. Like right now, you'll see in the guidelines, we have good guidelines written, whereby it says that, for example, an OST clinic supposed to be few meters or few kilometers next to the injecting den or injecting place. But here you will find a methadone clinic or any OST clinic is placed like almost 20 kilometers away. So it really demotivates, because for me to choose to go to an OST clinic would be very hard than me choosing going to a place where I can just inject and have my way out. And then also we need also to support community-led programs, community-led organization, and make sure we pump more resources to them. For instance, here now in Kenya, I'll give an example. In Kenya, we don't have any community-led organization that do service delivery to its people. It's the mainstream that serve the people who use drugs. So, that's, you know, how sometimes the DICs also bring stigma and all that. Improve access and affordable diagnostic and medicines, including HCV. We need actually to ensure that the government and all other programs actually come up with a wave on how to treat hepatitis C virus, because it's a problem. Even the first test, the second test for the PCR is very, very expensive. And also eliminating stigma, discrimination, and violence that stands as a barrier. You know, we personally, I'm having self-stigma when it comes to if I approach, for example, a public facility, because they've written there is a place they call CCC, clinical care service unit, whereby all people know that if you go to a CCC, either you are looking for ARV or you are looking for TB drugs, so you can imagine that stigma in those structures. So I think it's also good people to look for infrastructures that are very, very friendly to the people. We also need to look at the increasing of the number of sterile needle and syringe distribution for the people who inject drugs, at least from 200 to 300 per person per year. Still, the number is still low, but we can say that one can also minimize the challenge of infection. Reforming drug policies and creating regional harm reduction service charter that will guide us, the charter, the policy that will guide me when I'm in Tanzania, when I'm in Ivory Coast, when I'm in Rwanda, when I'm in Zanzibar. I should have a policy that really guides me as a person who uses drugs to access harm reduction services. Enhance funding, the funding for the harm reduction, and this is also for the whole key population, has really reduced. So we really are looking forward how DSD actually will also stimulate the funding model, so that the people who use drugs can be part of the concept development and planning, implementation, monitoring, and evaluation. Ensuring availability of naloxone in different modes. As I said earlier on, we are giving naloxone that are nearly to expiry date. But now also the other challenge is that we have policies that are saying the only person who can administer naloxone is a medical practitioner, certified medical practitioner. And you can imagine how many times our medical practitioner would go to the injecting place. So we need an nasal spray, naloxone, if it will be available, because now that is easy and also user-friendly for the people who use drugs. Key messages from the people who use drugs is that I want to say that I'm a human, not a medical specimen. I deserve to be fully informed before, during, and post treatment. As I shared earlier on, doctors, many medical practitioners get annoyed when you ask them questions. They feel you are challenging their professional. They think you are challenging what they went to school for. So most of the time, but I think it's something that needs to be built within us. Secondly, is that I'm a productive member of the society who possess individual agents to make decisions and choices about my health, body, and mind. One thing I want to tell the world is that we people who use drugs, we are very, very resourceful and productive when given an opportunity. So give us an opportunity to make decisions, to help you work together with us. Because the following message is that there is no harm reduction without me, and I have the right to make decisions around its design, implementation, monitoring, and evaluation. That is also affirmed the second bullet, the second bullet that people need to be considered as resourceful and not just as specimen. We need to be considered as partner, equal partners in harm reduction, and not like a threat, and not like just beneficiary. I am also having an experience right now. So many people will not invite you in their meetings because they feel you're going to give you a mind that is not really tallying with what they've been presenting to their donors. Communities are critical to monitoring the quality of harm reduction services. We not only need numbers here, but we need also the quality. The quantity is fine to reach many people as you can, but also we need in those many people that the quality of service, the quality of life of the people who use drugs do change. We cannot say harm reduction is very, very successful, yet we have people who cannot even raise to ferry themselves to the mat clinic. We can't say harm reduction is doing good, yet we have people every day are being killed in the streets because of mob injustice. We can't say harm reduction is doing well, yet women who use drugs are still queuing at the DICs looking for sanitary towels. It's very, very sad. We can't say harm reduction is doing well, yet women who use drugs are not fully empowered to go and report once they are experiencing violence from their clients. Lastly, is that people who use drugs should be front and center of HIV and health responses. This is actually sums everything, but it is important to ensure that the people who use drugs are at the centric point of decision making, at the centric point of planning, at the centric point to choose which kind of treatment fits them and what benefit will maximize in their lives. Thank you so much.
I'm sick of being labeled an addict. I'm sick of the whispers and stares as I pass. How careful people suddenly become when I come around. You see the wrongs, you see the crime, you see the filth and the bad influence. But please remember,
we are the people first, before we are people who use drugs.
I am Sipiso Twala. I am a person first. Yes, I am a person who uses drugs, but more than that, I am a father, I'm a husband, I'm a son, a brother, and so much more. I also have big dreams and aspirations like everyone does. Thank you.
My name is Violet. I am a person first. I have a name. Yes, I am a substance user, but there is more to me than just that label.
Bonjour tous. Je m'appelle Nzindu Contitus, je suis le président fondateur de l'association Empower Cameroun pour les usagers de drogue. Je suis un usager de drogue, mais je suis aussi une personne. Alors nous appelons pour un service différencié de qualité pour les personnes qui utilisent les drogues en Afrique.
My life depends on a symbiotic relationship between myself, opioids, and the human immunodeficiency virus. However, this relationship does not take away from my humanity. I am and always will be Retabile Sishabela first.
My name is Tyler from Cape Town, South Africa, and I'm a functioning person who uses drugs, and I'm more than just a label.
You can touch me, you can clash me, but please stop being nasty.
Mimi ni mtu kwanza, hata wakisema sisi ni PWID, hata wakichukia,
Yo people, I'm Ibrahim from Cape Town. I'm using drugs, but I'm more than just a label. I just want you guys to know that we want respect. Yo.
This is real life without edit. It's a struggle, an everyday struggle, and we're still in it. We want respect, and we're on a journey to earn it. Real life without edit.
people say paras, but they don't even know what's in us. The world we're living in is so corrupt. A couple millions under a president mattress, but we're out here on the streets so hopeless, with no success, but still calling us paras. We want respect like your people.
Kami, para pengguna nafsa di Indonesia, sedang berjuang untuk mendapatkan hak kesehatan yang sama, hak sosial,
Hak perlindungan hukum yang sama selayaknya manusia. Dan kami bukan label. Bukan komoditi. Bukan kriminal. Dan objek ekonomi.
Banyak urusan.
Yo people, I'm Donny from Cape Town. I using drugs. I have the right to rights. I just want the respect.
Hi, Natalie from Cape Town. I am a person who uses drugs, and I am not just a label.
I'm a person who uses drugs, and I'm more than that label, and at the same time I cherish that label because it connects my experience with that of thousands of people around the world who are doing their best to make sure that the world is a place where we all fit and no one is left behind.
Addiction recovery is more than stopping to use. We need to grow. We need to heal mentally, spiritually, physically, and emotionally. All we need is unconditional love and care, an occasional pat on the back. We are people first before we are people who use drugs. Support, don't punish. Thank you.
Good morning, good afternoon, good evening, wherever you are in the world today. I'm Kate Thompson, head of the Community Rights and Gender Department at the Global Fund. I'm also a person who used drugs when I was a lot younger. I will be co-moderating this session with Kerry Mangold from the South to South Learning Network. The session is focused on people who use drugs in Africa. First of all, I want to recognise that we are far, far behind in terms of responding to the diverse health and human rights needs of this community across the world, but particularly in the African region. This is the region where harm reduction interventions such as needle and syringe availability, opioid substitution therapy, and overdose prevention are unavailable in the majority of countries. Where these services are available in the region, just 10 countries for NSP and 8 for OST, coverage is often insufficient and there are barriers to accessing them. There are some positive signs. For instance, some countries such as Uganda and Mozambique began implementing OST programs in late 2020 and early 2021. However, punitive laws, policies and practices continue to severely limit the ability of health program implementers and service providers to recognize the very existence of people who use drugs communities, to understand their unique needs and deliver services in a way that is responsive to their needs. This is why community leadership alongside meaningful engagement is absolutely essential. It's what the Global Fund believes is the key to impactful programs, and we've placed it at the core of our new strategy. The positive impacts of community engagement on programs and health outcomes are well evidenced across the development and health sectors. Putting people at the center of designing, implementing and monitoring programs not only makes services more comprehensive and more responsive to the needs of people who use drugs communities, it also creates more enabling environments for greater service uptake, and it builds trust amongst those who our programs are intended to serve. Putting people who use drugs first will help address inequity in access to services. With people who use drugs in the lead, we will be able to effectively respond to the stigma, including self-stigma, discrimination and criminalization that stand in the way of effective, rights-based, gender-responsive health services. In this session, we will explore the roles of communities of people who use drugs across service delivery, advocacy, and community mobilization. And now over to Kerry.
Thank you so much, Kate. So I have the pleasure of introducing our panelists for the session for the community panel discussion today. So first, I would like to introduce Angela McBride. She is the Executive Director of the South African network of people who use drugs, and a woman who uses drugs. She is a part of many human rights and advocacy initiatives, as well as research projects and trainings on topics such as safer injecting and overdose prevention. Our next panelist is Marinez Mutongore, and he is the chairperson of the Key and Vulnerable Population Forum in Tanzania and a member of the Tanzania Global Fund Country Coordinating Mechanism. He was also previously the coordinator of the Tanzania Network of People Who Use Drugs. Marinez is a fighter for the rights of key populations, as he had experienced stigma firsthand from being a person who uses drugs. Welcome to our panelists.
Thank you, Kerry. I'm now going to ask each panelist to provide an opening statement on the topic. So Angela, first over to you for a 1-minute statement.
Thank you so much, Kate, and thank you, Kerry, for the introductions. My name is Angela McBride, and I'd just like to highlight today, especially, that when we speak of diverse service delivery for people who use drugs, it is important to note that we are people first. Noting that we are people first, it is important that we always acknowledge that there is a need for increase in access and availability of services for people who use drugs. But the need for diverse services beyond that of the basic health and well-being of people who use drugs is also important. And it doesn't have to be expensive or extensive. For example, the hashtag You Are Beautiful campaign that took place on the 8th of March 2022, celebrating International Women's Day with women who need a little reminder of their beauty. Thank you, Kate. Back to you.
Thank you so much, Angela. And now over to Marinus. Over to you for your statement.
Yeah, thank you, Kate. From my side, I say if we want to succeed with effective and efficient service delivery for programs of people who inject drugs, this is simple. And what we have to do is we need to have improved funding and less red tape PWID-led organizations. We need to promote PWID-led organizations to access funding and implement programs which are friendly, differentiated, and stigma-free to the communities of people who inject drugs. Thank you.
Thank you so much. And now back to Kerry.
Thanks, colleagues. So I think we'd like to hear a little bit more from both of you. So keeping in mind the title of this community panel being We Are People First, and what this means for differentiated service delivery for people who use drugs. Angela, I'll start by asking you this question. What does this mean for people who use drugs programming? Diverse and differentiated service delivery. What does this mean, keeping in mind the title of People First?
I'd like to highlight that it's not just about the amount of people who you're giving a service to, but it's also about acknowledging that person's individuality as well as their humanity. Because when I speak of myself, I speak that I'm not just a woman who uses drugs. I have my own story, and I would like it just as much as any other one to be able to be a person to remind and brighten another one's day ever so slightly. Because ultimately, this is not about you as a service provider. It's actually about the person who is accessing the services. And that's what being of service means. We want to encourage others in South Africa, as well as abroad, to do the same, to appreciate women for who they are and not what society labels us as. If I look like I need a little cheering up today, remind you that I'm beautiful, and do so too with a woman who you drive past the streetlight or you have seen sleeping under the tree. Show a little kindness and remind all women today that we are all beautiful. Because hashtag You Are Beautiful, with an aim to remind women that no matter what you look like, what you choose to do with your body, you are beautiful and worthy of love, compassion, and support, which is a diverse approach to service delivery. After all, we are all humans with feelings, dreams, and hopes. And yes, I am a person who uses drugs, but that's not where my identity ends. I am a person first. For more information, please feel free to check out our websites. And I would just like to say thank you for this opportunity.
Wow, Angela, thanks so much. I think bringing us back to, you know, the human, the individual, the personal kind of journeys and stories without labels is really quite critical, I think, and your message comes across really clearly in terms of, the design and framing of programs for people who use drugs, and a recognition that everybody here really is someone with aspirations, their own identity, and so diverse and differentiated service delivery really is critical using a human-centered design. So maybe I'll then ask you, Marinus, maybe if you could also reflect for us on the title of this session on people who use drugs being seen as people first and without labels. What do you think this means for funding and empowerment of community-led organizations in the response?
Yeah, sure. Thank you, Kate. From my side, I see that it is very important to support key population-led organizations, particularly people who inject drugs, to implement PWID-led programs in order to improve the reach, uptake, and provide differentiated services and stigma-free services to the communities, which most of them face stigma from the general population as well as self-stigma. So PWID-led organizations, when empowered, are much effective and efficient to obtain high results in linkages and retention and retaining clients to care and treatment. For instance, OST programs have been done very well, and the needle incentive programs have been done very well, and we can see improved outcomes when these are done by the beneficiaries themselves. I have an example. Let's say that if you have a lock in your show, no one other than you can know exactly how the lock feels. And others may just have read about locks, see locks, or even have a similar experience with the paper cord in a sandal. But however, you are the expert on this particular situation because you are experiencing it. So the same concept applies to considering PWID as people first. And PWID are the only one direct experiencing a problem and have a much different outlook on their needs than does an organization which is not a community-led organization who has only read about the problem in the newspaper or having a professional who once wrote a college paper on the problem. Actually, my example means a lot, and it means that why we see PWID as people first in things that are meant for them. So we as PWID need to be placed at the center of the programs that are meant for us. And we say there is nothing for us without us. That's why in order to improve all that, we need to properly engage and strengthen the capacities of PWID-led organizations to implement programs. And through that, we will expect positive fruits outcomes. Yeah, thank you very much.
Great, Marinus. Thank you so much. And thank you to Angela too. So recognizing the constraints provided by satellite sessions at conferences such as these, I think we want to just appreciate and recognize some of the provocations that we have had today from Kate, from Angela, from Marinus, and from the community voices that we heard in our video montage. While the topic of meaningful engagement of community members and networks is not new, I think it is prudent that we continue raising this up and talking about it. Considerations of letting go of the label, of people's right to rights, of using a user-centered approach. I think all of those messages are coming through quite strongly, even within these short time constraints. We've heard from this panel a call for increased community investment to steer and direct and lead effective responses, and an ask to prioritize self-determined needs of the various communities of people who use drugs. The South-South Learning Network, and I think everybody on this call, is committed to supporting its stakeholders and partners in continuing this discussion, especially as it relates to the scale-up of differentiated service delivery for people who use drugs. And I think really we wish to use the time saved on this video to have some live discussion and engagement on this topic. It's really critical that at least the conversation has started now, but we look forward to making the connections and continuing some of these really important messages in a forum beyond the boundaries of a conference and really into real life and into program funding. So I wonder if anyone would like to also provide a last closing remark or thought for the audience as we close out this pre-recording. So maybe I will ask Angela, Marinus, Kate, if you have any last thoughts or questions that you'd like to pose to the audience or final messages, please do so now.
Maybe I can just add very quickly that I am so delighted that this conversation is happening, and it's so important that the conversations continue, because this is such an important area where we need to make still so much progress, and it's great to be connecting with the leadership of people who use drugs on the ground in Africa. Certainly from a global fund perspective, I just want to voice our commitment to continue to working with you as we move forward in this area.
Angela?
Thanks, Gary, and thanks, Kate, again. Yeah, I just also want to reiterate the appreciation and the passion that comes from all of the activists in this field, but also from donors and funders who encourage the diversity of service delivery, who rather than restricting it and expecting service delivery to look like A, B, C, there is that we are allowed to have some fluidity and have some creativity. And I think if anything can be taken away from here, it's not only to constantly involve people who use drugs and services that relate to us, but also to make space for services that go beyond the day-to-day, to provide services that are encouraging, warm, and welcoming rather than clinical and restrictive. Thank you.
Thanks. Marinus, any last word before we close?
Oh, yes. I would like just to encourage the funders who are within our field to consider a PWID-led organization, also to be capacitated and implement programs, and that would improve the reach of key population, particularly PWID on the field, and actually have positive outputs rather than just prioritizing the organizations that are not well familiar with the field of we people who use and inject drugs. Thank you.
Yes, great. Thank you, everybody. And thank you to our panelists for sitting through that. I know it's hard. I believe we have Ahmed online. I don't know. We were hoping a third panelist could join us from the community, Titus, but I'm not sure if he's been able to connect. Just to acknowledge that Ahmed is joining us. It's over past 1 a.m., I think, from Kenya, so very dedicated. So we thank him very much for joining. So now it's open to questions. So please come to the microphone if you have questions. Those online, also please submit your written questions for any of our panelists. And if any of our panelists have questions for each other, you can go ahead. I guess just to bring Ahmed into the conversation, thank you so much for your wonderful presentation. And in this conference, we've heard a lot about community-led service delivery, and you touched on it a little in your presentation, but I'm wondering if you could describe for yourself what that would mean, and the WHO's focus on sustainable community-led service delivery. What would it take to create that, and what sort of capacity building is needed?
Yes. Thank you so much. I think from that, I really appreciate the question that's coming in because now for me, one thing I would say in Africa, I think if we are going to go with the WHO recommendation first, I think we need to expand resources in ensuring that when it comes to health, we have enough medical practitioners who can handle different situations. Secondly, I would also like to the service delivery also to be expanded to women, because today if women have serious reproductive health problem like fibroids and all that, they cannot be treated within the budget that is set for the DICs. We need to contribute to a person. We need to contribute to a person. So I think it will be very important if some of the services are going to be waived in terms of making sure everyone is involved. And in terms of structural, I like really the issue that we are people first before to be called the people who inject or use drugs. We are people first. So I think the human-centered approach should also be upheld. The second thing also I think I want to say to that is that we need also to be treated as partnership in these harm reduction services, not only as beneficiaries, because we matter, we have ideas, we might not have gone to school like any other medical practitioner, but we can manage our program because we have different networks across Africa that are run and owned by the people who use drugs. Thank you, and over to you. Yeah.
Great, thank you. Just as a reminder, you can come up to the microphones if you have any questions or would like to join in the conversation. I guess just asking our panelists who are here, picking up on what Ahmed said. Angela, you've talked a lot about, in your presentation, about women who use drugs and their needs. Are there any things that you think ministries of health, program providers consistently miss about providing services for women who use drugs?
Okay, it's on. So I think a lot of the time we get stuck on not only what hasn't or isn't happening, but also forgetting what has been happening and acknowledging the progress that has come thus far. I mean, being able to have safe spaces for people who use drugs that wasn't around 10 years ago. But just to have a space now and multiple spaces and have support from other organizations, from donors, from national representatives and government, that makes a big difference. And that's where the support comes in, and that's where change comes in. Because by involving people who use drugs, by acknowledging our voices, acknowledging our needs, we're able to address the challenges that are and the harms that we face. And the same obviously goes with women who use drugs. And again, referring back to the progress, there is a lot of need. There's a lot of things that still need to be done, and major harms and issues that need to be addressed. But we're getting there, and it's a process of progress. I'll say that right? Yeah, it is. It's working towards and together, supporting one another, you know, aiming for support, don't punish, aiming for, you know, being people first, being women first, acknowledging that it's not a one size fits all, and there are going to be, and there has to be, services made available, and more so available, and safe spaces for women, transgender people who use drugs, sex workers who use drugs, but just ultimately providing a platform where people can come together and say, I am Angela before I am a woman who uses drugs. But I think, yeah, just standing together and fighting together and acknowledging those needs and doing something, putting your next foot forward, and being kind as an individual. It starts with you, it starts with each one of us. It's easy to walk past someone and ignore them when they ask for a smoke or they ask for a euro or whichever the case may be. You may not have the cash on you, but it might be a good idea just to say, sorry, not today, or smile. And I think we forget how easy it is to treat a human being like a human. And that it can just start at home, even if that means having a box of tampons in your car that you want to, or that you can hand out, or sanitary pads in the boot of your car, that if and when needed, it's there. So I think if we speak about diverse service delivery, we need to look at our own responsibilities as individuals, as people, and ways that we can, without going above and beyond, because sometimes life does happen, but just taking time and taking space, or providing time and space and just listening and hearing a person for all of 30 seconds, because just asking someone how their day is can really make a huge difference. And that's the point of diverse and service delivery, is looking at healthier, happier, less harmful ways of addressing the needs of people who use drugs and women who use drugs. Thank you.
Great, thank you. And Morenas, I was wondering if you could, for our audience, describe a little more about the structure of the KVP Forum in Tanzania and how it interacts with ministries of health and the national AIDS programs, and what impact you've been able to see from advocacy in that way.
Thank you for the question. Yeah, as introduced before, I'm Marinus Mtongole, the chairperson of Tanzania Key and Vulnerable Population Forum, as well as the CCM representative for KVP in the Global Fund. In Tanzania, since the establishment of Key and Vulnerable Population Forum, we have been engaged through various decision-making spaces, like the National AIDS Control Program, structures of the technical working groups, as well as the Tanzania Commission of AIDS. So it was able to go and table issues concerning our communities. Key and Vulnerable Population Forum in Tanzania has been comprising of different constituencies. We are the People Who Inject Drugs. I'm the person there as a chairperson. So we have the other constituencies, like men who have sex with men, female sex workers, transgender, and AGYW. So we together have the seat within the technical working groups, and we table concerns from the communities. And before entering to those spaces, we have meetings we have with our communities, and we hear what communities says, what they need to be represented there. And actually, from that space, we are being listened. Those there's other issues that need support to follow under the country context, where it is difficult, but we're trying hard to make sure that the government understands. For instance, now there is the bill for people who use drugs, the bill that was passed criminalizing drug use. This is the bill that's it's a law that criminalizes drug use. But people who use drugs, when they are on streets, they use drugs, but sometimes we need to enroll them to the medical assistant therapy and other programs like needle and syringe programs. So the laws are contradicting, but we're trying much to make those government bodies to understand that people who use drugs, for instance, me, I used drugs for 17 years, since 2000. And after those 17 years, I abstained, and now I'm a recovering drug addict. But I'm trying much to help communities or other people. And it's very difficult when you use the drugs. It's very difficult. The withdrawal symptoms, every time they they keep you in, but sometimes there is a relief, and sometimes people do recover. So we, as we say, then we consider ourselves as the people first. We are the people before we use the drugs, and after my initiatives with struggling with the drugs, I was even invited to the parliament and I met with the prime minister and explained some concerns with the people injecting drugs. So together with that platform, we always make our voice together, and we have been advocating for resources for key and vulnerable population, and at least 5 organizations for KP-led organizations have been funded and are implementing programs. So the KP-led organizations are being led by the KP themselves, the people injected drugs, we tried to mobilize. We went to the University of Dar es Salaam for some colleagues who graduated on finance. We took those 5 financial personnel, and we employed them through these 5 KP-led organizations, because the person who uses the drugs sometimes can misuse the fund, maybe. But when we have the good finance system, the organization has good structure. The director is the person who uses drugs, but there is a strong system that monitors how the funds are being handled and implemented. And PEPFAR signed in these organizations to the programs, and now they are implementing programs. So that example shows that we at the key population, if we are given spaces, we can do much more. And actually, when you go and see, these organizations have been reaching the vulnerable groups, and the targets are being met, and they mobilize more networks of people injected drugs to get tested, to get in treatment. They are being retained. So that's the work of the communities. So the communities, if they are pressed first, we can do much and make sure that we end AIDS by 2030. Thank you very much.
Unfortunately, we are out of time for this, but there will be another Q&A at the end, so I'd ask you to hold your questions. We just want to make sure other presenters have their chance. Okay. Well, thank you, everybody, for joining us up here. And we're sorry that Titus couldn't join us. He didn't get a visa, unfortunately, and he's been having connectivity issues trying to join, but we appreciate his efforts. And thank you very much, Ahmed, for joining at this strange hour. I'm sure everyone appreciated your contributions as well. So now I'll hand it over to Moses, who will introduce our case study presentations. Thank you.
I think we should give them another applause. This was a wonderful presentation timed to the dot. So my name is Moses Bateganya, and I work with FHI 360, and it is my distinct pleasure this evening, this night for colleagues in Africa, and this morning for other countries, to introduce 3 key presenters who are going to share some case studies that highlight some of the programs that are really have introduced differentiated service delivery models. Together, these 3 presenters have over 50 years of experience, so we are in the right room. I will start by inviting Dr. Maria Simbine up here, who is from the Ministry of Health in Mozambique, and who is a clinical psychologist. She serves as the focal point for the National Harm Reduction Program, and has spent a lot of time really working with implementing partners in Mozambique to introduce harm reduction, substance abuse prevention models. Please have a seat. And then next, Dr. Mary Mugambi from Kenya, who is a public health specialist and who has been working in HIV programming, really a range of services from HIV testing to prevention, and now has actually worked to introduce a lot of differentiated service delivery models in Kenya, focusing on key and vulnerable populations. And last, my colleague Chris Akolo, who I should be able to introduce without speaking because we work together. Chris has is a director at FHI 360 and for the Meeting Targets and Maintaining Epidemic Control EpiC project, which serves key populations and other vulnerable populations. So we are going to listen to some recordings again, and then we'll have a live Q&A. So welcome, panel. Thank you.
Greetings, everyone. I'm Marie-Helena Simbini, and I'm going to speak about the drug use prevention and harm reduction pilot program in Mozambique. In 2008, we introduced the pilot for harm reduction program in Mozambique with the convention from the Minister of Health, the National Council to Combat HIV/AIDS, and the Drug Control Cabinet. We started to give some servers among the mental health service in Sofala and Nampula, and Maputo we established a community health center. Because from how we know, the HIV, the prevalence from HIV people who inject drugs was around 31% between 2008 and 2021, compared to the general population was 13.2%. People who inject drugs are high risk of other infections, and for the prevalence for hepatitis C among those people was around 44.6%. People who inject drugs face barriers and that prevent access and to use the health and social service, indicate the need of comprehensive harm reduction program for the population. So with this program, we managed to conduct the objective from the project was to prevent accession of HIV and other infection among the PWID, promote harm reduction strategy and actions, focus on public health and human rights, and even to reduce the risk and the adverse consequence of injecting drug among the people who already inject the drug, families, and the society. We have managed to integrate this activity, this program, in two levels. The first level was the community level, and at the community level, we have all the prevention for ITS, TB, HIV, and even refers those people from the community to the facility, to the clinic. And there at the clinic, we managed to give service like Naxalon treatment, health mental service, post-GBV care, STI and TB treatment, methadone therapy. We managed to do the therapy substitute opioids with methadone, hepatitis B and C service. On to preparing and enable the environment for this pilot, we first developed the supportive policy, include the national plan for prevention and harm reduction. We had already had the national guidelines for key population and the integrated mechanism for GBV prevention and response. We managed also to enable this pilot. We trained community outreach workers, police officers, community leaders, and people who inject drug focal points in government institutions on harm reduction to prevent violence, stigma, and so on. And integrate was very crucial to integrate civil society organization in technical group works on drug use prevention and HIV. Integrate organization lead by people who inject drugs, and community leader was one of the things that we enabled to do it along those pilots. So for the result that we get from our pilot, the first was that we managed to we managed to register 696 people on the community health center, and from those 200, 421 was the people who inject drug. We tested the people for HIV and hepatitis C. We could manage to distribute the needle syringe and needles among those people at the community. That was a community service, and also to distribute some condoms. Now we can see the graphic about the people who've been reached, the people whose drugs have been reached with HIV prevention, testing, and treatment service among the 2018 and 2021. And as we said, we started in 2008, and we can see we are a little bit shy. We only managed to reach 430 people. At 2009, we could reach more people up to IRT, testing for HIV, and even the prevention intervention. And between 2020 and 21, unfortunately, due to COVID, the number that we could reach was lower because all the restrictions about the COVID-19. We face some challenge and so on. We face some challenge, and the challenge that we face was regardless to limit human resource for adequate offer adequate treatment, limit financial resource to establish multiple health centers and expand the service. The harm reduction approach for people who inject drugs are not included in our corridor for health care service or social service, even for the police are not offered. The people who inject drugs, they are most of the time being arrested, and that unfortunately lead to interrupt and the treatment that they've been carrying on, and don't enable them to get access to the social and health service. For our lesson learned, we can say that we saw that it's very important and critical to train health providers and establish a reference health facilities among these people. It is important to increase the advocacy for among the decision makers, because we had to hand our needle syringe programs because they can't understand, and the pilots was also very effective to reach the people who inject drugs. For the next steps, we have to mobilize resources to build more community centers and expand the service, train providers, healthcare providers for the harm reduction treatment, and even we need to develop a package for police, law enforcement officers, and so on. And it's very important to establish harm reduction task force responsibility for generating evidence. And that is all. Thank you all.
Good morning and good evening. My name is Mary Mugambi from NASCOC, the Ministry of Health in Kenya. I'll be presenting on differentiated service delivery for people who inject drugs. HIV among key populations is important because of the contribution to new HIV infections, and the new infections that are contributed for 2020 was about 13% of new infections. For the key populations program, we implement for female sex workers who have a prevalence of 29.3, men who inject drugs at 18.2, people who inject drugs at 18.7, and the general population prevalence in comparison is 4.9%. Looking at the population estimates for female sex workers and for all the other populations, they are at 197 for FSWs, about 61,650 for men who have sex with men, people who inject drugs at about 26,000, and transgender at about 4,000. In the decade of programming with people who inject drugs in Kenya, we estimate at around 35,784 people who are injecting drugs, and that is according to the Kenya Population Size Estimates 2020. And these people are found in different areas, in specific street alleys and injecting dens. And about 11% of those people are below the age of 18 years, and 15% are women. In the same injecting sites, an additional 10,000 people were estimated to be using drugs. So this program offers comprehensive package of services and combination prevention approach with equal focus on behavioral, biomedical, and structural interventions. And Kenya has adopted 2 key strategies for harm reduction. That is the needle and syringe program and opioid substitution therapy. Drug possession and use remains criminalized in Kenya. And for people who inject drugs, there's a lot of high stigma and discrimination, especially for women. In the evidence to develop a supportive policy to environment to scale up, we have prioritized people who inject drugs in the national response based on evidence and data, and we have included them as a priority population in the national strategic plan. We've developed guidelines. We've formed meaningful partnerships with community-led networks and implementing partners. We've advocated with funders and community-led organizations and implemented a monitoring system for the program. So Kenya initiated the needle and syringe program in 2010. This was to reduce harm among injecting drug users, and in 2014 the program was scaled up with specific implementation guidance. Needle and syringes were provided at the drug locations through peer educators and in the clinics through service providers. Peer educators from the community are selected and trained, and they provide peer education and distribute new needles and syringes. And we have a peer ratio of 1 to 30 for people who inject drugs. And these peer educators are responsible for specific locations and specific sub-locations. The NSP program is linked with clinical services, which are provided in the drop-in center and integrated in the public health sector. Kenya scaled up the OSC and MAT program in high-priority counties, and this began in 8th December 2014. And our current inclusion criteria is all drug users with a focus on women. And we have 11 medically assisted therapy sites across the 7 counties which are offering methadone. We've included MAT also in prisons, and decentralization of MAT dispensing has taken place with the initiation of MAT in prisons through mobile vans. More treatment options have been initiated, including buprenorphine, and medically assisted therapy program also provides other HIV and SRH services, including HIV testing and treatment, viral hepatitis treatment, and in future this scale-up is going to happen in the civil society organizations and the private sector. Kenya established an enabling environment to facilitate provision of differentiated services where advocacy and awareness has been done with policymakers, community leaders, and religious leaders. We've had sensitization and training of police, led by the people who inject drugs, advocates and judges to consider options other than incarceration, media reporters and media persons for positive coverage. Also, we've had strengthening community groups and annual peer conventions and stakeholders meetings. And this is to hear programming challenges and develop solutions. Under monitoring of the program and using data for decision making consistently, we've used program data, and looking at just what we have on this slide is ever enrolled for the medically assisted therapy program has been over 8,000, would be about 10,000 by now, who have ever enrolled on MAT. We also have those who are currently on MAT and retention. Retention on average, as you can see, is between, has always been on a onward. I mean, sometimes it goes up, sometimes it goes down, and depending on the situations at that point in time. Our challenges in relation to providing differentiated services for people who inject drugs is identifying new people and living with HIV and retaining these people who inject drugs and living with HIV. Also, scaling up sustainability of MAT clinics is a concern. The costs to set up and maintain are high. Also, sustainable livelihoods for those who are on MAT are a challenge. Addressing comprehensive needs of women and young people, laws related to drug possession and use, including violence against people who use drugs, are just some of the challenges that we face. Thank you very much, and I acknowledge the following.
Hello, everyone. Thank you to the organizers of this session for the opportunity to share experience with differentiated service delivery for people who inject drugs in Nigeria under the USAID-funded EpiC project led by FHI 360. My name is Chris Akolo, and I'm a technical director with FHI 360. I have no relevant financial relationships with ineligible companies to disclose. As a way of background, with support from the Key Populations Investment Fund, FHI 360 through the EpiC project implemented a 2-year program in Niger and Bayelsa states to strengthen and expand comprehensive HIV programming for key populations, including people who inject drugs. The project directly engaged the governments in these 2 states, key populations-led and key populations competent organizations to deliver comprehensive package of services. We engaged local organizations that were already reaching this community. The Kindling Hope Across Nations, CAN, in Bayelsa State, and Center for Communication and Reproductive Health Services, CCRHS, in Niger State. While the HIV prevalence among people who inject drugs in Nigeria is around 3%, this population accounts for up to 9% of new HIV infections. Of the approximately 200,000 people who inject drugs in Nigeria, about 6,000 of them were estimated to be in the 2 states, and this is based on results of a programmatic mapping exercise that was conducted by EpiC. It is important to note that in Bayelsa, people who inject drugs are mostly clustered around the creeks and coastal communities where oil bunkering occurs, while in Niger State, they are mostly around the mining sites. To ensure proper engagement and buy-in from the community, the project conducted the following activities: a scoping visit to each of the states to identify and to partner with local community-based organizations that have the experience in programming with the target population, including those that were already engaging community members as peer providers and as program staff. Gatekeepers such as drug barons and other members of the community were also identified, and they were fully engaged. A programmatic mapping exercise was conducted to understand where to find community members, what kind of services were available, and the information gathered was used for microplanning. All identified stakeholders and community members were sensitized, and relevant peer providers and program staff were trained on the package of services available within the project. The team introduced the following DSD models to ensure people who inject drugs were able to access the needed HIV services: a provision of comprehensive package of services at one-stop shop or at the drop-in centers, and this site served not only those of people who inject drugs, but also other key populations, including sex workers, men who have sex with men, and transgender persons. Differentiated HIV testing services, including the use of the enhanced peer outreach approach, which is a form of social network testing, index testing for both sexual and injecting drug partners, were all introduced. In some instances, members of the community who were trained peer navigators offered some of these services, and they were also responsible for linking their peers to treatment where applicable. Those who require HIV treatment, ART was offered through various models, such as community ART teams and support groups. The other DSD models include community pharmacies, and in some instances, home delivery of ART for clients who saw this as a convenient option, especially within the context of COVID-19. To ensure improved viral load testing coverage, the use of DBS for sample collection was introduced, especially for clients in hard-to-reach communities. It's important to note that harm reduction services were generally not available within the program. However, counseling services around harm reduction were provided, and clients were linked to other services where available. In terms of program performance, between January 2020 and December 2021, the program consistently achieved HIV case finding of above 5%. and the range was between 5.1% and 14.2%. Meanwhile, the overall prevalence among people who inject drugs in Nigeria is 3.4%. This chart shows the HIV case finding rates by testing modality. While most cases were identified through community outreach model, case finding was highest through index testing. EPOA and HIV self-testing were introduced towards the end of the project. In FY21, that's between October 2020 and September 2021, all clients, a total of 429 of them, newly diagnosed with HIV were linked to ART. Of the over 1,000 individuals who were due for viral load, 91.3% of them accessed viral load testing, and suppression rate was 97%. For the negative cascade, of the over 4,500 clients who tested HIV negative, 84.5% of them were screened for PrEP, and all those who were eligible were initiated on PrEP. In terms of overall reach and impact, over the 2 years of implementation, more than 1,000 or more than 15,000 clients accessed HIV testing services. Over 1,300 of them were newly diagnosed with HIV, and all were linked to ART. Overall treatment continuity was 98%, and viral suppression was 97%. Over 2,800 people who inject drugs were newly initiated on PrEP. The following are some of the lessons learned from the implementation of the program in the 2 states. Partnering with local key population-led CBOs and engaging them from the design stage through implementation led to critical buy-in from the community. The use of peer-led approach facilitated ownership and access to community members. Scoping, mapping, and the introduction of micro-planning principles helped the program to tailor and to target services. Although COVID-19 restrictions affected reach and the ability of the program to mobilize more people for services. The engagement of law enforcement helped address some of the security challenges in the 2 states. The rollout of differentiated service delivery models led to strong program performance across the clinical cascade. The integration of harm reduction services into the program could have made the program more comprehensive and enhanced the overall impact. I would like to thank all my colleagues that contributed to this presentation, the entire EpiC team in Nigeria, all our partners, particularly KAN in Bayelsa and CCRHS in Niger, and all the program beneficiaries. Thank you for your attention.
So again, join me in thanking the panel here for excellent recordings and also for being here on the stage. On the stage to share these 3 exciting case studies. There are not very many case studies in Africa that offer this kind of really good work that is attempting to make services client-centered. We are over time by a few minutes, and I know that there is dinner also to be had, but I thought we would give ourselves a few minutes to at least take 1 or 2 questions from the room, and maybe 1 from the audience. Yes, just come to the microphone. So, brief questions as we are out of time.
But I'm pretty sure that people here would like to hear everybody, both questions, and they will delay their dinner a little bit. I'll try to be short. My name is Louis Letellier de Saint-Just. I'm a Montreal lawyer, human rights and health lawyer. I co-founded in 1989 the first needle exchange program here in Montreal. And in 2017, we were the 2nd safe injection site for people who inject drugs in Canada. Thank you. The 2nd because we had to fight. In 2009, the Canadian HIV Legal Network, Cactus Montreal, and Harm Reduction International, as a coalition, we went to the Supreme Court of Canada to fight for the life of the only legal safe injection site in the country. And we came out with an unanimous decision from the Supreme Court, making sure that a safe injection site is a health service. So this is an achievement. In 2012, the Canadian HIV/AIDS Legal Network, with an offender, Stephen Simons and Katie, here in Canada, had to go to court again to make sure that we could have access to harm reduction services in prisons in Canada. It happened in 2018. My message is, even though it's harder in Africa, and I know because I worked in Africa for a couple of years, building the course on human rights and public policy on drugs in Senegal for French African countries. And I'm sad that there's no representative from this part of Africa. Or I'm wrong, maybe, but that's what I see. It's important that you go to court. You have the African Charter of Human Rights. You can use that. You can go to the African Court of Human Rights. And it works. Many times. My question is, knowing that there's no representative of French African countries, how important is the problem of injecting drugs through Africa? Is it the same? I have part of the answers, of course, but I would like to hear from you. Is it the same importance in Northern Africa as it is in Southern Africa or in West Africa? Is the response the same?
Thank you so much for that question and also sharing the experience. We're going to move this side, and I'm sure if there's nobody here from West Africa, there might be somebody in the audience, or Chris, who actually provides technical assistance across multiple countries, might also share some experiences. Over. Yep.
John Bosco is my name. I work with ICAP Kenya. My question goes to the presenter from Mozambique. During your pilot, you indicated that clients who faced violence were screened at community level and referred to facility level for care. Did you explore the provision of first-line response to these people at community level, for example, using the lives approach? And then, were you able to follow up with the retention for clients who were diagnosed at community level, then referred at facility level? Because we know as long as structural barriers exist, the continuity in the program at facility level still may be challenged. And did you also explore probably the option of establishing safe places at community level such that these people can be habited at that place before sending them to the facility as they recuperate? Thank you.
Thank you so much. We're going to take one more question, and I think that should be all from the room. And there's no question online, then I will allow the panel to respond.
Thanks.
Thank you.
It's more generally a comment. I'm Judy Chang. I'm the Executive Director of the International Network of People Who Use Drugs. I just want to express appreciation and, say how really amazing and great it is to really see all this progress on harm reduction and programming for people who use drugs over the last few years in the region. I think what we've also seen as well is, really seeing the development and strengthening of networks and, the elevating of the voice of people who use drugs as well, to be able to be here and define, what differentiated service delivery looks like for people who use and inject drugs as well. But I think now what's, of course, really important is, how do we not backpedal from this work, right? How do we not only, continue and progress this work, but really, focus on how to bring, harm reduction to scale within the region. So, of course, one of the big political funding opportunities is the Global Fund replenishment. We know that the Global Fund is the largest funder of harm reduction services in low and middle income countries. And, just the message that we really need a fully funded global fund, and to make sure that harm reduction is really present and visible in the NFM4 and the funding requests, as well as community leadership. So,
thank you, Judy. And yes, since nobody is living in protest, I would assume that you are all in agreement that we take one more question.
Thank you so much, and thanks to all the panelists for the presentation, and also the second panelist. My question is to ask you, in all the work that you've done with LGBTI communities involved, because I think within the work that we do in our countries, it's important to recognize the intersectionalities. Like, for an example, I'm the founder of the National Sex Worker Movement in South Africa. So we do recognize the intersectionality, and we know that within the sex workers, there are LGBTI communities that are sex workers. There are trans female sex workers. There are also male sex workers, and there are also female sex workers. And also just to acknowledge the work that you've done. Thank you so much. That was just my question. Thank you.
Thank you so much. So I think we're going to go maybe starting with Chris to comment first of, I think, on the legal, I think just hearing from our colleague from Canada on whether there have been attempts to go to the Supreme Court. And then Dr. Simbine, you can also address the other question, and then we go to Dr. Mary.
Yeah, thank you very much. I think I'll start with that last comment. And I think I referenced that in my presentation that, for example, the one-stop shop or the drop-in centers that we have for people who inject drugs also service other key populations, like sex workers, men who have sex with men. I think I mentioned that. So that just shows that we're thinking about that intersectionality between the various key population groups. In terms of the legal, definitely I'm speaking from the perspective of an implementer, and I'm implementing on behalf of PEPFAR. So I think that context will help you to understand what my response would be. We are not doing much in that particular area, and despite having programs across 30 countries, mostly in Africa, I can tell you that right now with PWID programming, we only have very, very few countries, less than 5 countries. And we're just beginning to go into that space right now, based on all the legal environment and the lack of enough funding, the lack of population size estimates. I think the first presenter actually highlighted, if you look at most of the African countries, we don't even have an idea of how many people who inject drugs exist. So how do you program for people that you don't even believe exist in the first place? So I would say we're not doing much in that particular area. And like you mentioned, there are a lot of opportunities, and there are a lot of things that could be done. But I think it will require a multi-sectoral approach. We cannot approach it, or we cannot handle this alone as healthcare providers, or just looking from HIV angle. It requires the entire system to be able to help address some of these issues. Thank you.
Thank you. Dr. Simbine. Yep.
Thank you. Thank you for the questions. Just like I said, harm reduction for us in Mozambique is very new. We just started in 2018, and it's criminalized to use and possession of drugs. Even for the needle and syringe, for us, it's very complicated. We started, but we had to stop because of the politicians, because some laws say that we cannot work with most of 2 needles and syringe, so it's complicated. So we are now fighting to reopen the program of needle and syringe. And yes, we do the screen for VBG. As our peer educations, they have a certain service they offer, the change of behavior, explain how to use even the needle syringe when we are able to distribute them. And they screen for VGB, we use the lives, and then those peer education, they refer to community center, and then the community center goes to the health facility. And the health facility, we can manage to treat and all those things that is supposed to do. Our retention, it's good. Thankfully, we have now about 400 people in OST, and leaving the OST, it's between only five people, and we have a good service on OST, and we have unfortunately only one clinic for methadone, and we are willing to expand in more to province in Mozambique, and on this OST. We have about 1,000 people on wait list. So imagine how it could be and is being to provide the service. So yes. For the safe places, we have this community center. The community center offers the first levels of service of healthcare, and even the needle syringe before the pre-education, TB, IST, HIV, and all those things. But we don't have a safe place to ingest them. It's not, the law doesn't allow it. But otherwise, they can wash, sleep, eat, and do some work. We have a social work in the community center too, so they can be reached to the family when they are OST and all those things. Thank you.
Thank you. And last, Dr. Mugambi.
Thank you very much. Thank you so much for the questions. First, I'd just like to appreciate the lawyer who's pushing for our rights and that we can go to the African Court of Human Rights. I think that's a challenge for us. How important is harm reduction in Kenya? It's very important. And well, I know, as Chris says, it came through the HIV. Before, we were not addressing harm reduction. So HIV kind of became a blessing, so to speak. I don't know if I can put it that way, because we were able to address the issues that come with everything to do with HIV. There was a comment on how do we scale up. Just to appreciate the donors, the Global Fund and PEPFAR, who support the harm reduction in Kenya. I think the biggest thing in scale up is beginning. As Mozambique has started small, you begin and then you learn from your mistakes, but you must begin somewhere. The most important thing we've been able to do recently is start different innovations in terms of harm reduction, like using a van, for instance, so that people can get access. It's very expensive to run a methadone program when clients have to use a lot of transport to get to the facility to get their methadone. So it's important to get to the client instead of waiting for the client to come for the methadone. For me, I think that's the biggest problem. And focusing on the civil society organizations. I know Hamed spoke, and those are one of the champions for the civil society organizations. And capacity building them so that it is them who are making decisions. Working through communities so that we get women who are using drugs, because the stigma for women is double stigma. If there's stigma for a man, the stigma for a woman is 10 times. How does she come for her methadone? And you know she's judged by the society. So I think just getting those populations out and making sure that they're getting the services that they need without stigma. The law issue is very serious in Africa. I think most of the countries, yes, it's still criminalized. And that is a very big challenge, but we still work through that structure that is there. For instance, you saw we work with the police, just making sure that they understand that anybody can be a drug user. There's a very thin line between being a key population and general population. I don't even know why we say general and key. I think the line is very thin and it's porous. You can be on either side. You use drugs, you're selling sex. I think it's a problem within society, but we must be able to see everyone as human and everyone having issues, and everyone needs to live in this country, in this world, so to speak, and everyone has their human rights, which must be respected. I think that's all I can say. Thank you.
Thank you so much. And a few seconds, okay, thank you. Yes, please, go ahead.
Well, the word is patience. I know most of your legislation, the legislation in Africa are repressive. I know that. And that's a big burden for you. It's a wall. But just to give you a last example, how patient can do things. Recently, we had a court decision in British Columbia. The judge refused to send the lady who was selling drugs for her own survivance. The judge refused to send her to prison. And this case will go to the Supreme Court based on human rights. So that's the message I was sending to you. Be patient, but think of the tools you have in hands as well.
Thank you so much. And with that, on that note, we are going to close, and I will turn it over to Cassia to close us out.
Sorry, they were asking us to leave because we're way over. But I've been asked to plug the launch event for the UNODC is launching their 2022 World Drug Report tomorrow. And that's at 10:30 in the morning in the UNAIDS room 519B. So people here are welcome and encouraged to attend that launch event. Thank you very much, everybody.